Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers, producer of Public Health on Call, and we want to hear from you. In more than 500 episodes since March 2020, we've been bringing you the latest on urgent public health topics like COVID-19, climate change, gun violence, monkeypox, racism, and more. We'll continue to cover these, but we'd like to know, what other public health topics would you like to hear more about? Plus, you can enter to win some amazing podcast swag, including the beach tote featured on our Twitter account. Please go to publichealth.jhu.edu/publichealthoncall/survey to take a brief survey of potential future topics. This will be open until September 9th, and that link is publichealth.jhu.edu/publichealthoncall/survey. We're excited to hear from you, and thank you so much for listening.
Today, polio. I speak to Dr. Olakunle Alonge, an associate professor at the Johns Hopkins Bloomberg School of Public Health, who studies polio eradication efforts around the world. I asked him what's happening now and what can we do about it. In this podcast, Dr. Alonge sometimes refers to the live oral polio vaccine as OPV, and to the killed inactivated polio vaccine as IPV. Let's listen. Dr. Olakunle Alonge, thank you so much for joining me to talk about polio, a disease that you have been working on for quite a long time.
Yes, thanks, Josh, for having me. It's really a pleasure to be with you today to talk about polio. And indeed, I've been looking at polio for quite a while now in different parts of the world.
So polio is caused by a virus. What can you tell me about the virus? What do people need to know? And what kind of diseases can polio cause?
Yes, polio is caused by a virus, which is transmitted basically through ingesting contaminated food and drinking contaminated water. So it's basically through what we call the fecal-oral route. And what it does, it's in the severest form, it causes damage to the nerves that controls some of our voluntary muscles, including the muscles we use to walk, to hold things, to breathe, to talk, and so on. But in most cases, it causes a mild form of illness, which presents almost like your regular flu or some other kinds of minor viral infection, basically fever, muscle ache, headache, and so on. But in about 25% of cases of people that get infected, they could have meningitis. That is to say, symptoms that reflect neck stiffness. They're in a lot of pain. And then in very rare cases, maybe 1 in 100 or between 1 in 100 to 1 in 500 cases, you would have paralysis, what we call the acute flaccid paralysis, which usually involves weakness and paralysis of the muscles of the lower limb. Yeah,
that's sort of how we think about in the United States, the iron lungs, the pictures of kids in iron lungs often were from paralytic polio. What's the history of polio around the world? How many people have been affected, say, over the last decades or centuries?
Wow, that's a tough question. Over the last, I think we can take it back to 1988, which was really when the world got together to have a plan to eradicate polio from the face of the globe. At that point, there were about 350,000 cases reported annually every year. And since that time, there's been a lot of concerted efforts through vaccination programs, surveillance, community engagement, and different kinds of activities to address polio. And right now, we we have polio just endemic. I mean, the white polio virus just endemic to two countries, Pakistan and Afghanistan. And we also have seen a reduction of the cases to about 99.9% from the 350,000 annually that was recorded at the onset of the eradication program. But the eradication effort has also been created some peculiar challenges in that because of some issues around vaccination coverage, particularly for some of the viruses that are derived from the polio vaccine itself. We do have cases of vaccine-derived polio viruses, which is different from the white polio viruses, which is what we see it's emerging in a number of countries as we speak.
Got it. So the wild type polio infections down more than 99%. And really only happening in two countries, but then some other polio infections caused by a form of the virus that's used in the vaccine has been elsewhere. How does that happen? How does a vaccine virus turn into an infection?
Yeah, that's a great question. And then it's I mean, to answer that question, we have to talk about the two types of vaccines that we have for addressing polio. One of the commonly used vaccine is what we call the oral polio vaccine. Oral in the sense that it's administered through the mouth. And this vaccine contains the virus itself, even though it's attenuated, that is to say it's weakened, but it still contains the live virus. And then the second type is the inactivated polio vaccine, which contains the killed version of the virus. So in a number of countries outside the US, the oral polio vaccine is the mainstay for vaccination program. Obviously, for a lot of reasons, it's easy to administer because you can use it rapidly in campaigns and so on. But in some instances where you have very rare instances, I should say, maybe one in 2.5 million cases or so, when you administer the oral polio vaccine, you could have a scenario where the vaccine is transmitted, the oral polio vaccine virus, which we call the Sabin virus, is transmitted from somebody who received the vaccine to somebody who is susceptible. That is to say, they don't have any immunity to polio. And in the process of the vaccine or the virus in the vaccine being transmitted or existing in other hosts, it can replicate. And while it replicates, there are some changes that could happen, genetic changes that could happen to the vaccine, in which case the vaccine can, even though it was attenuated in the vaccine, but the virus can revert back to a strain that can really cause damage. And that's what we find that is happening now. And there are a number of factors that can lead to that.
I'm going to ask you about those in a second, but just so I'm totally clear, you have the killed virus in a shot. That's all that's used for vaccination in the United States right now. But in other countries, the oral live virus is used. And you were saying 1 in 2.5 million cases, it might turn into a virus that can actually spread, particularly to people who have no immunity. That's
correct.
Right? Okay.
Yep.
And you were just saying that there are certain factors that make that more likely?
Yes. And usually the important thing is to recognize that if people do have immunity, so the number of individuals that are susceptible to being infected with the strain of the virus from the vaccine, it's really going to be low or almost non-existent. So the critical element is really ensuring that there is adequate vaccination coverage within the population. And so most of the outbreaks of what we call the vaccine-derived polio viruses that we see happens in communities and among population that has a fairly low immunization coverage.
So how many countries around the world in a given year will see a case of the vaccine-derived polio infection? Is that a common thing every year, or is it pretty rare?
Yeah, it's becoming commoner by the year. I think as of 2020, we have about 33 countries that have reported outbreak of the vaccine-derived polio virus, and where we have seen paralytic polio, which is linked to community transmission of those vaccine-derived polio viruses in those countries. To date, I think there's close to about 1,500 or between 1,500 and 1,600 cases of paralytic polio as a result of the vaccine-derived polio viruses.
Wow. So that's the fear right now in the United States and other countries that haven't seen polio. It's not the wild type virus that's still located in those two countries. It's the vaccine-derived virus, which has been affecting about 30 countries a year, and the potential that it could find pockets of unvaccinated people in the United States that's causing the concern. Is that right?
That's partly right. So the majority of the concern is related to the vaccine-derived polio viruses, but the same factors that allows for the vaccine-derived polio viruses to cause infection and to cause paralysis, paralytic polio, also applies to the white polio viruses as well. So when you have community that have low immunity, and then you have somebody come from some of the endemic countries into the United States, for instance, you could have an outbreak. I mean, God forbid, but it's a possibility.
Got it. We're really talking about susceptibility to polio of any kind.
That's
when
correct.
Vaccination rates go down.
Yeah, that's correct.
Let me ask you, before I ask you your recommendations for countries that have cases like this, I wanted to ask you whether you think the strategy of using the oral live polio vaccine is being questioned given the number of cases that have related to the vaccine. Have people considered switching to the inactivated version?
Yeah, it's a great question, and it's a question that I've been asked at different forums, and there are really no straightforward answers because both the oral polio vaccine and the inactivated polio vaccine that is given as a shot do have played critical role in the eradication program to date. So while countries like the United States that has the resources and the means, obviously it's advantageous to only use the inactivated polio, the vaccine, the killed shot. And that has been the recommendation since the year 2000, actually. But in the countries where we have oral polio vaccine being still in use, there are a lot of reasons why this is the case. One, obviously, is the resources to be able to, and the capacity to be able to provide the IPV, that's the inactivated polio vaccine, and also the fact that the ease of administration and the less reliance that you have on strong health system in order to run campaigns for using the OPV. And the OPV also has other advantages for rapidly addressing person-to-person transmission in community because it actually prevents not just the disease, but it prevents the infection as well.
So it sounds like the fear would be that if you switch just to the inactivated killed virus vaccine, you wouldn't be able to vaccinate as many people in some of these countries, and they could be susceptible to major outbreaks of polio virus.
Yeah, that's correct. So you two things. You don't have, the world doesn't, as of now, doesn't have enough supply of IPVs to cover all of the population in the world. That's one. And then two, you really need strong or relatively stable health system in order to be able to administer shots. You have people, you need doctors, nurses, clinicians to administer the shots, as opposed to going from house to house, just giving drops of the oral polio vaccine. So again, there is the issue of capacity to do that. And so if you switch, if we ask the rest of the world to switch to the IPV, it's likely going to create more problems than solve the ongoing issues that we have with the vaccine-derived polio virus. And I must say that one of the reasons why we do have a significant outbreak of circulating vaccine-derived polio viruses has been linked to the way the global community manage the switch of one type of the oral polio virus. So I didn't talk about this earlier, but we have different types of OPVs. We have OPV1, OPV2, OPV3. OPV2, which addresses the white polio virus type 2, was a candidate for a switch in 2016. So in 2016, when the world certified that white polio virus type 2 had been completely eradicated globally, there was a switch to encourage all countries to use IPV2, that is to say, to replace OPV2 with IPV2 in all communities. But however, the issue that I talked about earlier on really portend against the success of this. So there wasn't enough IPV doses. There wasn't capacity to administer it. And what happened is that we had an immunity gap for the type 2 virus, which actually then led to the circulating vaccine-derived polioviruses type 2, which is the commonest type of the vaccine-derived polioviruses, which again continues to transmit as we speak.
So it's not just the theory that it could lead to more polio cases, but the actual experience that the switch could be dangerous. So that brings me to what to do. We now are finding evidence of poliovirus in the sewage in New York, for example, and potentially other places might follow suit. We have populations in the United States that are poorly vaccinated, and in particular where young children are poorly vaccinated. What is your advice based on your experience all around the world for a country like the United States that has not seen a case of paralytic polio for many years and now suddenly has one?
Yeah, I think there are evidence-based practices that we can emphasize. If they're well implemented, we should be able to help to address the problem. One of the major things is vaccination. I mean, it's really it's vaccination. You want to really target those pockets of population where the vaccine coverage for the polio vaccine is low, and you want to address some of the root causes of vaccine refusal or the reasons why people are not getting vaccinated in those communities. And then the second thing is really to be able to do campaigns quickly, to be able to respond to outbreaks quickly. One of the main strategy, like you did mention, is environmental surveillance, where we actually test wastewater to see the strains of viruses within the community. And the interesting thing is that you tend to see the vaccine-derived polio viruses in the wastewater weeks before you see cases of paralytic polio in the community. So if you are able to respond adequately, if you have good quality response to your environmental surveillance findings, I think that is also very crucial. Now, what you need to do when you see such environmental cases is really to do campaigns, to target campaigns to the communities that are affected. And also related to that, you really cannot address the issue of vaccination without overcoming some of the root causes of low vaccine coverage, which differs from community to community. So you really have to be engaging with the community. And yes, you have an evidence-based vaccine, you have evidence-based practices around the vaccine, but that doesn't necessarily translate to impact, as we've seen, not just in the United States, but in a number of countries. So you really have to be talking to the community and to be finding solutions together to some of the societal problems, social problems that may underline a vaccine refusal.
Very, very important to understand why people are refusing the vaccine and help them overcome their doubts. Let me ask you one final question. You have worked on polio many years all around the world, and now you're seeing the United States touched by this. What are your thoughts about global eradication efforts in this context? Do you think that this might support a stronger global effort? Are you concerned that it will lead to undermining global efforts? How do you see the world coming together against polio?
Yeah. I think there's a silver lining to this. And then one of the silver lining is the fact that this is most likely to help the Global Polio Eradication Initiative. Unfortunately, we don't want outbreaks in the US or in the UK or in Europe. But these cases, this outbreak really do allow population in these countries to see that polio is still very much with us. And then we've seen that all of this infection or the transmission came from outside of the United States, came from outside of the UK. And so we begin to recognize the interconnectedness of communities. So for us to have a successful eradication program, all hands must be on deck. And I think the fact that we are seeing cases in the US, it draws attention of legislators, people who have the means and the influence to rally around the eradication initiative. Some of the challenges the eradication initiative has been having in recent times is related to funding, related to political will, related to advocacy. And I think the influence of countries like the United States, like the United Kingdom and other Western nations really can translate positively for the Global Polio Eradication Initiative.
And if that initiative succeeds, then there's no more polio on the face of the earth and nobody needs to be vaccinated. Is that right?
Absolutely. Yes, absolutely. So it's we win together or we fall together. Absolutely.
Dr. Alonge, thank you so much for spending time with us on Public Health on Call, and thanks for your incredibly important work against polio all around the world.
My pleasure. Thanks for having me.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.